patients including UK, Australia, Africa, Middle East, especially in UAE, Palestine, Lebanon and Bahrain. So she is going to present the nursing leadership and legal nursing development experience to the building, build our capacity.
Good afternoon, and thank you, Mr. Chairman, and hello, ladies and gentlemen. So we've had a very interesting session this morning, and we've heard a lot about all of the challenges facing us in kidney care globally. The majority of that has largely been around interventions and discussions around what nephrologists can do. By Irving Zola, and it's called The Upstream and Downstream Story. And I've chosen this lovely river in Pakistan to talk about it. But the story, as I tell it, goes that there's a doctor and a nurse standing on the banks of the river. Let's stand here on the banks of the river here. And they're having a chat, and then all of a sudden they see this person come down in the river, screaming and shouting, drowning, clearly drowning. The doctor jumps in immediately and saves the patient, saves the person, brings them out onto the bank and starts to resuscitate them. Less than a few minutes later, another person comes down the river, screaming and shouting, wailing and drowning. The nurse jumps in, pulls the patient out, pulls the person out and onto the bank and starts to resuscitate them. This happens on and on for about the next 15-20 minutes. More and more people are coming down the river, clearly in distress and about to drown. And the nurse and the doctor take it in turns to jump in and save them. After a period of time, with all these people laying on the bank of the river, the nurse gets up and walks away. And the doctor says to her, "Where on earth do you think you're going? You can't leave me at this point." And she says, "Well, actually, I think I'm going to walk further up the river, up here, and find out why everybody keeps falling in." I think it's important that we think about all of those issues in terms of upstream and downstream and the impact that they can have on what we're trying to do, and they're certainly essential for building capacity. My slide's not moving. So in terms of building capacity, we talk a lot about it these days, but what do we actually mean? Well, it's about having an ability to achieve our goals effectively, having strategies to identify and secure the resources that we need to succeed in what we're trying to do. It's about information and often education, developing resources, financial management, and also organisational learning, instruction and guidance. And critically, it's about leadership development. If we're going to build capacity, we have to have people that are going to be leaders who can drive change and push things forward. So basically, it's any set of actions that an organisation takes to improve its ability to perform successfully in its chosen area. It's really important because it encourages leaders to evaluate their own abilities to perform in a very complex environment. And as we've heard this morning, particularly in relation to some of the issues around kidney care and CKD particularly, that's important. So things like the early detection of CKD would be a prime example of trying to build capacity and looking for ways to manage a complex environment. So you need to look at ways that the organisation, or indeed the individual, can develop staff so that they can provide new services that enhance programs and services. Traditionally, professions in healthcare have worked not so collaboratively necessarily in terms of the capacity. So some examples of how they might have worked historically are around coexistence. So rather separate functioning professions working within their own silos and doing their own thing. Maybe some cooperation. So saying, well, yes, I think that's important, but I've got to do what I'm doing first, and then maybe I'll look at what you're doing later. Coordination, maybe thinking that people need to adjust what they do to avoid overlap and confusion, but still not really collaborating wholly. But when we look at things like collaboration and co-ownership, that's quite different. If we're looking at true collaboration, we're saying, let's work on this together, and let's be responsible about the outcomes together. If we have professional integration, it has massive benefits for collaboration and co-ownership. So we get an increased reach to the population, so we have massive impact, a greater critical mass, strengthened negotiating power, new and effective ways of doing things, greater flexibility, and also shared costs. Quite often when it comes to initiatives for capacity building, people will worry about it and think that it's going to cost more money. But in fact, when you pull all of these things together, it's quite amazing to see quite often that they are actually cost saving. In terms of nursing leadership, nurses have been involved in capacity building for many years, and if we look really historically, we can remember Florence Nightingale, and everyone will remember her story of working in the Crimean War and actually being the founder of modern nursing. Now, Florence had absolutely no previous experience of war, but she was a highly educated woman. When she went to Crimea, she wasn't particularly popular with her medical colleagues. She was a bit of a busybody and interfering quite a lot. But during her experience, she became quite an expert nurse practitioner in terms of clinical practice. She also became an expert administrator. She noticed that it was important to pull together all of the issues around management of services, making sure that resources were available, staff were available, etc. She was also a highly skilled technician, statistician, and collected meticulous data and analysed it. And it was through those activities that she managed to transform clinical practice in the Crimea, which led to breakthroughs in clinical practice, particularly related to infection and mortality, knowledge, skill, and application to practice. She was an absolute formidable force for change, and she had a continuous pursuit in excellence in nursing. If we fast track to 2019 and look at leadership in healthcare today, we can see that it's in fact a $366 billion industry. 95% of organizations across the world invest in leadership development for their staff, and most of it fails to deliver the results that they expect. The reason for this is the lack of context mostly. Leadership programs are developed very generically without looking at the context of the organizations people work in. There's too much reflection, poor understanding of culture, and when I talk about culture, I'm not necessarily talking about culture of where people live or where they come from, but also organizational culture and the culture of professions. And also in terms of data, it's important to understand that what gets measured gets done. If you can't measure it, you can't manage it, and leadership programs need to ensure that that is included. So leadership, many of the programs that you will see that are offered in organizations are transformational leadership, servant leadership, organizational leadership. Basically, everything that they talk about, everything about leadership is about change. It's just about seeing a problem. It's about seeking opportunities for change and being comfortable with it, using examples from sectors not necessarily your own, and prioritizing what's important. What's important isn't always what's the most urgent. Listening to others and influencing others, transforming ways of doing things. So in our steps to capacity building, first of all, as professions and interdisciplinary, we need to agree a need for change and identify between ourselves the strengths and weaknesses that we need, and evaluating internal and external factors. We need to make sure that we have leadership enhancement of management structures, processes and procedures to meet present and future needs. And this is about systems leadership, so it's not just about one single organisation, it's about understanding the impact of that on others. Because consequently, capacity building is a very long-term process. And it's quite common that as you make improvements in one area, you'll get problems in another area that require attention. This is the law of unintended consequences. So as a consequence, capacity building requires that we have commitment and perseverance. So why is all this important in kidney care? Well, we've all heard this morning about the data on the global burden of CKD. In other halls, they've been talking about the increasing prevalence of AKI. We need to develop services to manage these burdens because what we have is not meeting those needs at the moment. There's a massive complexity on the demands of our roles. Management of patients on renal replacement therapies, and also more upstream activities like nurse practitioners in early detection, home therapies, and even things like putting renal nurses into places like critical care to identify risk of AKI, etc. In 2017, the ISN came up with a global kidney health roadmap for closing gaps in care. They identified 10 themes to enable that to happen. In order to make it happen, the proposed activities included education, research, policy creation, etc., among many, many other interventions. And this was all targeted at healthcare institutions, government agencies, industry partners, so all very upstream, but also clinicians. And I've put that in red here because by clinicians, I'm not talking about, even if that's what was intended at the time, I'm talking about clinicians as being everyone involved in kidney care, so all members of the multidisciplinary team. World Nursing in 2019 is a very challenging place to be. There's been a big move towards an all-graduate profession, and that's coming back again because we know that we have an absolutely massive shortage of nurses globally, and also of doctors. There's been a massive lack of investment in education and training. And then in response to all of these things, there have been many extended roles or changes in roles or professions. So nurses have been trained to absorb some of the task-related activities of doctors. There's been a rise of technician-type roles for nurses. So for example, we've heard of nurses inserting PD catheters and other catheters, etc. And then, as a result, nurses have had to delegate some of their responsibilities to others. So they were delegated to technicians and care assistants. Dialysis is seen as under threat in terms of nursing because in many centres now, nurses don't even practice in dialysis units and it's mostly run by technicians. But it's important to understand, as renal nurses, for those of you that are in here, that renal nursing isn't about dialysis, it's about a lot more, and we have to be able to prove our worth and why we're necessary to contribute to this initiative. So yes, renal nursing is not dialysis nursing. There are many different roles within renal nursing. We're looking after patients with long-term conditions who go through a huge continuum of care. They have very complex needs with multiple comorbidities, and nurses have to be able to understand this and care for those patients appropriately. Nurses have to be able to develop their own leadership skills to be able to drive this forward and drive change. And they need to be able to influence policy. Nurses have to be at the forefront of these activities. Bloom's taxonomy describes the 3 domains of learning which are important. And nursing has traditionally focused on the doing part of this. So you can see here these 3 domains. This is cognitive, this is about your education, your knowledge and what you know. This is your psychomotor, this is your skills and what you can do. And this is the affective, and this is about your development and also your approach and your attitude to the way that you work. So we've always focused mostly on this psychomotor training and neglected some of the underpinning knowledge and development of behaviours that best support practice. But it's important also to know that when programs focus too much on the theory at the expense of practice, then that is also a weakness. The fact that educated nurses are necessary in terms of good outcomes for patient care is well documented, and this is just a study that was done and actually produced in the Lancet, so that was very important for us as nurses. You can see here that a study that was done in 300 hospitals across Europe, and the workload bit is important, but the bit that I want to draw your attention to here was that for every 10% increase in bachelor's educated nurses, decreased mortality by 7%. So therefore a hospital with 60% of bachelor's nurses caring for 6 patients would have a 30% lower mortality than a hospital with 30% of bachelor's nurses. So having educated nurses with high level of expertise makes a difference. In the UAE, where I've been working for the past 8 years, when I first started, I did a comprehensive learning needs analysis of our nurses working within kidney care. And at that time, they were working mostly within hemodialysis. And they were very skilled technically and very able to do their jobs. But they were very lacking in their underpinning knowledge. And really worryingly, they lacked any confidence at all to discuss or challenge. So 49% of the nurses didn't feel confident to challenge any clinical decision made by any member of staff who was senior to them. So this is important in terms of making sure that we get good care. As a result of the learning needs analysis and many other metrics that were measured from that, we started a master's, a specialist renal nursing master's in 2014. At that time, that was the only master's course in the United Arab Emirates. We partnered with De Montfort University in the UK. And importantly, this program was very different from any other program that had been run before, in terms of it was very much based on clinical expertise and leadership, not administration and management. We were very clear we didn't want nurses going through a 2-year program, putting a certificate on the wall, and then staying in an office doing administrative tasks. This wasn't a management master's program, it was about clinical practice. So all of the learning was embedded in clinical practice. Our first cohort graduated in 2016, and it was really about growing the nurse leaders of the future for sustainable kidney care. This is just an example of the program and how it looked. So it covered absolutely everything about renal care, kidney care. So not just dialysis. Dialysis is a tiny part of it. So our nurses graduated from this program being able to do advanced health assessments on patients, having gone through leadership programs in context of kidney care, and being skilled researchers. These were the places where we made sure that they had to go and get clinical experience. So they did placements in all of these places. So the nurses had to come out of this program having understood and worked with patients from dialysis to transplantation, vascular access surgery, and critical care as a few examples. For the nurses in the audience, you'll be familiar with Patricia Benner's model of moving from novice to expert in clinical practice. And our nurses all started the program around the competent or advanced beginner level. When they had completed, they were all up here in either proficient or expert level. And it's at this level here where you get nurses who are able to take on leadership roles and can be real forces for innovation and change. We showed a massive impact in our program to demonstrate how important it was. These were just some metrics. They're not really that important, but these are some metrics that were used to measure our performance within the organisation. And you can see, well, back in 2012, we were not achieving any of our targets in terms of clinical outcomes, and we were benchmarking against DOPS, which is on the right-hand side. By 2018, we were achieving all but one of our targets and exceeding DOPS in several of them. Nothing had changed except that we had educated our nurses and changed the way that they practice. So I think it's important that when you do these things that you can measure the impact of what you're delivering. As a result of the program also, now nurse-led initiatives that have been started, because those nurses who developed high levels of expertise were able to then, in their own right, go on and lead and develop services. So nurses that completed the program led a vascular access program. I'll be talking about that tomorrow and the great outcomes from that. A nurse-led CKD early detection program and a nurse-led home therapist program. So this is all about building capacity within that country. In terms of clinical practice and moving education within two different cultures and different organisations, this gentleman here was one of the senior managers in our organisation who enrolled onto the master's programme because he wanted to do a master's degree, but was very reluctant to get back into clinical practice. He'd spent his whole career trying to get out of it and was very happy doing administrative tasks. I assured him that the only way he was going to really be able to develop as a leader within the organisation in terms of nursing was to get his scrubs on and really understand what clinical care and delivery is all about. And he did. And I think he was very grateful and has ended up being one of our most successful nurse leaders. There are many nursing leadership models, and most of them really don't meet the mark. I've made up my own, and my leadership model just involves these four core components, which are knowledge, skill, courage, and care. When we talk about care, it's about not forgetting to care about the patients, not forgetting to care enough to support, advocate, and develop and promote our other colleagues, managing productivity, and having a good vision for the future about always thinking that things can be better. In terms of skill, it's time working clinically. I can't overemphasize how important that is at all levels, no matter how senior you become. And valuing the clinical aspect of your role to inform decision making, being a role model, and having first-hand experience of what it's like on a day-to-day basis for the front line. In terms of knowledge, you must always commit yourself to ensuring that your clinical practice is underpinned by up-to-date evidence, being expert and familiar with research, thinking and trends, and learning how to learn. Ensuring that you always pass on the good stuff, not old recycled stuff, and definitely not Wikipedia. And courage. Having the courage to believe in yourself. As nurses, I think sometimes we get a little bit intimidated and we don't have the courage to do that. You have to stand up for your patients. You have to stand up for your colleagues. You have to engage your colleagues in difficult discussions and influence and drive change. And most importantly, you have to have the courage to fail, because you will sometimes, but it's always about learning. This is another slide to show that since the program that we started, and including some in-service education, this is the number of hours of education delivered across the bottom. And this was our crude mortality. And so back in 2012, you see our crude mortality of our patients was just under 11%. And after 4 or 5 years of the program, our mortality had fallen to under 5%. So the importance of collaboration cannot be overestimated. We have to work interdisciplinary and truly interdisciplinary education and cooperation. Sometimes it feels a bit awkward in the beginning. It's vital to find like-minded people. It's important that our doctors understand they can't do this capacity building all alone. And nurses, you need to understand and speak up. You need to join professional groups, join societies or your own. Reach out to a mentor or be a mentor. The ISN itself has been, as I mentioned in the roadmap, building capacity and developing lots of programs, most importantly the educational programs for nephrologists. But I'm delighted to say that back in 2016, this was expanded and now includes nurses for the first time. So we now have a nursing and allied health task force within the ISN called the Kidney Health Professionals Working Group. And that is now the nursing leadership and voice within the ISN. And so far we've had 2 publications. We now have a nurse on every regional board in the ISN and nurses leading educational ambassador visits. These are just some slides of one of the educational ambassador visits that we were doing. Again, building capacity. This was in Kenya. Okay, this was a little cartoon that I think speaks volumes about when you're trying to convince organisations and professions about building capacity through expertise. There are some that get it, some that don't, and some realise that there is nothing to get. So back to my river. Last night I think we all agree that we need to build capacity. And to build capacity, we need to develop expertise. I was hugely inspired last night by the stories of your esteemed professors who have been working hard right up here at the top of the river and developing kidney care in Pakistan. As from this quote up here by Isaac Newton, they truly are giants. But you know, nurses can be giants too. Thank you very much.